I'm Andrew Powell, another one of the foot and ankle specialists here at ONS. Just want to thank you guys for spending a good part of your Saturday with us, listening. The ONSF Foundation, thank you for giving me the opportunity for this talk, and thank you to Dr. Vitale for setting this up and putting it all together. I see a lot of familiar faces in the crowd, and it's nice to be back. So my talk is on what's new in the treatment of ankle fractures. I have no relevant disclosures for this talk. So ankle fractures, as we're all quite familiar with, is the most common interarticular fracture of a weight-bearing joint. They come in a wide variety of presentations, as we all see. And the optimal treatment is not really a cookie-cutter process. It really depends on the patient whether to treat it with surgery, treat it without surgery, assess the risks and benefits. And there's a lot of different factors at play when we encounter ankle fractures in the clinic. And a good outcome is dependent on a congruent reduction. We all know that from the literature, malunion of the ankle leads to abnormal pressure distribution and subsequent post-traumatic arthritis, which then leads to those ankle replacements that Dr. Pasternak was talking about. And the choice of surgery depends on whether open treatment will really provide superior results to closed treatment. So these are challenging things I see in clinic, and there's a high cost. And the cost is not just the cost of the surgery, not just the cost of the patient, the implants, or the potential hospitalization. It's a societal cost and the occupational disability that results from being out of work and not being available for your family, not being able to drive a car for these right-sided fractures as well. So there's a lot of different factors at play. So traditional classifications, most of us are quite familiar with the Logie-Hansen classification, the Weber classification, and the AO classification. So Logie-Hansen, as we all know, it's basically based on the position of the foot during the injury, and then the mechanism or the direction of the force applied to the foot, so such as supination external rotation or pronation external rotation. The Weber classification is based on the level of the fibula fracture, whether it's below the ankle, right at the ankle joint and the syndesmosis, or above. And the AO classification really focuses more on the location of the fracture and the amount of comminution. However, it's not really as simple as just classifying, every ankle fracture doesn't exactly fit into one of these classifications cleanly. And even current literature has called into question the intra and inter-observer reliability of these classification systems. So it's only a tool. It doesn't really dictate, all treatment. So the three topics I wanted to just briefly focus on today in terms of ankle fractures are early weight bearing, whether to fix the deltoid ligament on the medial side of the ankle, as well as intramedullary fixation of the fibula. So early weight bearing, the risks of bearing weight too early, whether it's if the fixation is going to fall apart, if the fracture is going to displace, if you're going to have increased wound healing complications. Those are definitely the risks of early weight bearing. And even in residency, which is not too long ago for me, traditionally we make everyone non-weight bearing for 6 weeks. And we've really gotten away from that depending on the fracture. And more of the literature now shows the non-inferiority of early weight bearing after stable fixation. And a lot of these systematic reviews or randomized control studies do show that early weight bearing after stable ankle fracture fixation shows earlier return to work time and better short-term outcomes as well. I will say that some of these studies are limited by not classifying the type of ankle fracture, so they're not really specifying whether isolated lateral malfractures or trimal fractures or pylon fractures, so you kind of have to take this with a grain of salt. But there definitely are, as a lot of therapists in the crowd know, a lot of benefits to earlier mobilization after surgery, such as, less scarring, better range of motion. Patient satisfaction is also increased as well. So we know it's safe. The next topic is the deltoid. So we all, have been in these situations where you see the medial side of the ankle open up, as you can see in this picture on the right, and whether to fix the deltoid. So what is the deltoid here? So it's a broad complex of ligaments that stabilize the medial side of the ankle. They're basically stratified in superficial and deep components. Traditionally, there hasn't been a lot of consensus on whether to fix or not. And traditionally, it's really been about, people have talked about more stabilizing the syndesmosis and in turn, closing down the medial side. And as I've gotten more and more into practice, I really, truly believe that it's a separate entity and has to be addressed on its own. So this is an example of a deltoid repair. So in this picture on the left, you can see the x-ray in the top right corner. It's a left ankle. You can't see the fibular fracture because it is higher up, but the medial clear space is significantly widened. As you can see, the talus shifted laterally with respect to the plafond. These are arthroscopic images from the operation which show a torn deltoid if you look at the medial side. So on this right-hand image here in figure A, you can actually see where the star is, where the small white star is. That's the bare surface of the anterior aspect of the medial malleolus. So that's not really iatrogenically created. That's once you open up the medial side, you're sitting there staring right into the ankle joint. And the reason that you're staring right into the ankle joint is that the anterior aspect, or the superficial deltoid, has been completely avulsed off the anterior aspect of the medial malleolus. So in this case example, they're using a rongeur to prepare the surface of the medial malleolus and to drill some suture anchors and basically to imbricate that deltoid and to bring it back. So the third topic is fixation of a fibular fracture. So this is something that we're all quite familiar with, and traditionally the gold standard for treatment has been plating it, with lag screws or without lag screws. Put a big plate on, but there are definitely some costs to this and some risks. So it's a much longer incision. You can imagine just how long it took the surgeon to close the incision and how big the incision is here, and the higher propensity for the incision to become infected or have delayed wound healing complications. And also, you have increased disruption of the blood supply as well. So intramedullary fixation, not really a super new thing, but it has been described since the late 1980s. The technology has significantly increased over the past 5 to 10 years, and early designs were fraught with complication with lack of rotational and length instability. Some of these early designs and some of these early implants did not have any fixation proximally or distally, and that led to a lot of failures. So these are more modern designs where you have the intramedullary nail. There's more instrumented design to get the nail inside the canal, and more importantly, you have proximal and distal fixation. And also you have options for syndesmotic fixation, whether it's screws or suture tape augmentation through the nail as well. So there are a lot of benefits, as you can imagine. So exposure requires a lot less soft tissue dissection, a lot less hardware prominence because you don't have a bulky plate that you can feel on the outside of your ankle. And a lot of skinnier individuals, sometimes have these plates removed subsequently because they can feel them or have persistent pain. So less risk of hardware removal. And a lot of these principles are honestly similar to intramedullary nailing of other long bone fractures. So the literature has started to show that there's potentially less complication and less hardware removal for intramedullary fixation. This is an example of something that, of a case I had about 8-9 months ago, where it was a 30-year-old individual with a pretty comminuted distal tibia fracture, which extended into the joint. And he also had this transverse fibular fracture as well. So because of the distal tibia fracture, I had to make a long incision on the anterior medial aspect of the leg. And instead of making a second, longitudinal large incision on the lateral ankle, this was a good indication to use intramedullary fixation because it's just one poke hole distal to the tip of the fibula to insert the nail through, and then right where the screws are to put the screws in. That's really all that's needed for this. If you don't need to use any clamps to reduce it, like in this example, it's just two centimeter incisions on the lateral side instead of a much longer incision. So in summary, definitely have become more liberal on weight bearing post-op. I will say that it doesn't just mean everyone that you fix can weight bear immediately or weight bear 2 weeks. It really relies on stable fixation when leaving the operating room. It also relies on a reliable patient that's motivated and will comply as well. Everyone, a lot of lateral malfixation, if it's isolated, I have started weight bear at 1 week or 2 weeks if the wound looks okay. But a lot of tri-mals and bi-mals and pilons, it's more of a 4 to 6 week ordeal of non-weight bearing, to me at least. But I try to get these people in a boot as soon as possible once the wound looks good to start active range of motion to get that stiffness. Definitely inclined to fix the deltoid more if stress views suggest widening. And for these high fibular fractures, definitely an indication to consider intramedullary fixation. Thank you.